Thanks everyone for joining.
Yeah, so we can get started. Welcome everybody. My name is Mari Boson and I work with the Alberta SPOR Support Unit. And before we get started, I would like to acknowledge that although we are meeting virtually, each of us live on the traditional lands of First Nations, Métis, and Inuit people, whose histories, languages, and cultures continue to influence and enrich our vibrant community. I am pleased to welcome you today to this session on Cirrhosis Care Alberta, finding real-world solutions for complex chronic disease management. A couple of notes of housekeeping, which you have probably heard 10 times by now throughout the virtual institute. This session is best viewed in speaker view and not gallery view. Please keep your video camera off to ensure your privacy and to prevent interference with your audio. And to access the reaction buttons, such as the thumbs up, click on participants at the bottom of the live stream window. You will then see the reaction icons at the bottom of the participants tab. If you have questions, please post them in the Zoom chat box or in the Whova Q&A box. And we have Donna Presic from the Alberta SPOR support team here helping to moderate those questions. If you experience technical difficulties, the best first step, as always, is to exit and rejoin this session. This session is being recorded and you can watch the recording later when it gets posted in Whova. So our speaker today is Dr. Puneeta Tandon, the founder and co-director of the internationally recognized Cirrhosis Care Clinic and Edmonton co-lead for Ascend. Dr. Tandon is passionate about empowering her patients with practical tools for reducing stress and improving well-being. At both the national and international levels, Dr. Tandon has spoken as an expert on liver disease, nutrition, exercise, and chronic disease symptom management. Take it away, Dr. Tandon.
Okay, awesome. So I collapsed that the picture view just because it was hiding some of the text, but thank you for those of you who made time to come, and yeah, thank you for inviting me to speak. So I'm just going to go through a little bit about our Cirrhosis Care Alberta project, which is a PRIUS funded project, and really try and take you through why this is important and some of the evidence to support the strategies that we are working on, and take you through a roadmap of our program. So for those of you who are not that familiar with cirrhosis, it was termed in one of the Toronto reports back by Maurice Sherman in 2013 as a crisis in the making. And I think this will be something that we see more and more of. It's increasing in prevalence. The treatments for hepatitis C related cirrhosis have been getting better, but still we're going to see a peak in 2020, 2030. Fatty liver disease related cirrhosis with the obesity epidemic is taking over, so it is going to increase by 170% by 2030. Cirrhosis is a leading cause of death. Transplantation, unfortunately, is an option for a minority of patients, so only for 10%. And it's a leading cause of death in younger patients, so patients age of 45 to 64. Huge resource implications. So when we were prepping for the PRIUS write-up, we did some administrative data review looking at what was happening provincially, and you can see length of stay of these patients is almost 2 weeks with a $22,000 cost per admission. And once they get admitted, their chances of getting readmitted within 3 months is 44%. People are very familiar with COPD. And so we compared our cirrhosis costs to COPD costs, and you can see they're actually very similar. So cirrhosis patients are fewer, but take up a lot more acute care utilization. And in the literature would support that 30% of these readmissions are preventable, so we can do something about it. Now, these patients are unfortunately some of the most complex, not only medically with all of the problems that they have going on, but also psychosocially. And so it's that complexity that really, I think, makes this a very special group to put more intensive resources into. And like many of our patients, it's complex patients navigating an extremely complex system, which often is not actually very patient-centered. So trying to run around and get them to do all of these different things without a clear path for them. So recognizing all of this, back in 2010, Michelle Carbonneau, who's the nurse practitioner down here, and myself started the Cirrhosis Care Clinic. And so that was my first year in practice. And at that time, we built up from one patient to, adding on practitioners. And so we've added on Dr. Abraldez, we've added on Kim Newnham as a nurse practitioner and a part-time dietitian as well. And over the years, we've followed anywhere from 300 to 500 patients with cirrhosis at a time. The clinic is excellent. It provides guideline-based liver care and education, this dietitian support, and early discharge support as well. And it's made a difference. And so this was some research done by Michelle Carbonneau, looking at 212 patients where we compared the Cirrhosis Care Clinic care versus standard of care, which would be a hepatologist alone looking after the patient. And cirrhosis clinic care was associated with reduced length of stay in hospital, as well as improved survival and decreased cost of care. So this is an excellent kind of model to try and replicate to improve outcomes. And so 10 years after the cirrhosis clinic started, we got the opportunity to, and Michelle actually came to me and said, we have to do this, to apply for the PRIUS. And the PRIUS opportunities, as you probably know, are joint funding opportunities with the goal of helping Albertans to manage their health conditions and maintain their independence in their community, was this particular call, and avoid unnecessary acute care visits and admissions. And so that's what our project is termed the Cirrhosis Care Alberta program. Now the core team for this, Michelle has been seconded to do part-time work with us in content. Ashley is a postdoc. Derek is our team lead for our patient advisory team, which is about 20 patients. Emily is now a master's student. She was a research assistant on the position last year, and then a posting that's upcoming for an overall manager of the project. And this team, we are supported by an interdisciplinary team across the province of 100 co-leads and collaborators and our advisory council. So it's a big group of people trying to really make this mission move forward. So when we started to write up the PRIUS grant, we really needed to think about what are the gaps in our care. And there are many gaps. And, I think that all of these need to, in some way, have some attention given to them if we're actually going to shift the dial on care. And so I'll go through a little bit of where the gaps are in these three areas of cirrhosis complications, broader health needs, and then this effective transition into the community and across providers. So gap number one, when we look at the literature and when we look at our own data as well, only about a third to at best a half of patients receive guideline-based care for their liver-related issues. And that's despite having really good, solid guidelines out there. We're really far behind, even more so on best practices for broader health needs. And so things like alcohol intake is somewhat prevalent in this group, second major cause of cirrhosis. And it influences over 50% of admissions, but less than 20% actually, when they're in hospital, get any sort of structured screening or brief interventions. And we know that medications help to reduce cravings, but less than 5% receive that. Malnutrition and frailty are huge in this population. 50 to 80% of them are malnourished. And when we do audits of our in-hospital patients, about 20% are actually meeting nutrition and activity targets. And then our third gap is this idea of transitioning care. So once they're an inpatient and then they go back into the community, that care linkages is often a weak point. And so discharge education, we know from various studies, it's been associated with fewer readmissions, but when we've done our interviews with each site in the province, no hospital site have any sort of standardized discharge education for cirrhosis patients. They do for CHF, they do for COPD, but they don't for cirrhosis. Patients we know who have an involved primary care practitioner have fewer readmissions, and yet less than 10% of primary care docs are actually informed of admission or discharge. So this is a major issue and a reasonably quick fix. And then what I mentioned before, that 30% of these admissions are potentially avoidable, and yet our patients will continue to go to emerge if they're not given an alternative. And so focusing on these common causes of admission, ascites and hepatic encephalopathy or confusion, is important. Another gap around that is that we really lack role clarity. So there's many players in the cirrhosis journey for patients, many practitioners who are in that. We know that this is like a tsunami that's going to get at us with the number of patients that are increasing, and we really need to organize ourselves a little bit better as far as who's doing what, both in inpatient care and then in transitioning into outpatient care. So how can we do this with limited funds? So the PRIUS is a nice grant, but it unfortunately we can't cover the entire province with a very expensive solution. So we need something that's sustainable on limited funds. And so that was our challenge. So we thought, okay, what many people wanted when we said, oh, we got a grant to improve cirrhosis care was, let's just build cirrhosis clinics all over the province. But of course, that's nurse practitioner funds for one of those or two of those clinics would take up the entire funding. So that's not a sustainable solution. And we thought, well, should we try and do nurse practitioner-led clinics in Edmonton and Calgary, and they can sort of take care of everybody. And again, unfortunately, not sustainable on the PRIUS budget. But what we thought would be sustainable is to try and provide a model to support all of these providers and to support our patients, and also to get a little bit more role clarity going on as far as who's doing what. So at least somebody is doing, somebody's taking ownership for some of the management principles. So this is our basic solution. So I wanted to share with you some evidence that we can do this, and then we'll go on to what we are doing. So with regards to delivering best practices for these patients, this was a really nice study of 824 patients where they used an order set to promote goal-directed lactulose therapy and rifaximin therapy for confusion, and then prompts for antibiotic prophylaxis of infection. And what they found was that there was a 40% reduction in 30-day readmissions with that, and a reduction in length of stay. Okay, so basic order set intervention. Broader health needs. There's been several studies looking at this, not necessarily in cirrhosis, but this was nutrition-focused programming. And so this group did malnutrition risk screen, giving patients oral nutrition supplements and dietitian consultation as needed, with some standardized patient and caregiver nutrition education. And they similarly found a 25% reduction in length of stay and 30-day readmission rates. So powerful things that can help with inpatient care. Alcohol is another one of our big focuses. And so just to share with you the impact of alcohol use disorder treatment on these patients, this was a really large administrative cohort study of 35,000 veterans. And what they found was, number one, there was only 14% of these patients who actually received any behavioral and or pharmacological therapy for their alcohol use disorder. But those who did reduced the hepatic decompensation, meaning that they didn't get the complications of cirrhosis as frequently, and they reduced all-cause mortality. And it works. So there's been several reviews and a systematic review, most recently looking at number needed to treat for one of the more powerful medications, acamprosate. The NNT is only 12. So really, this is something we need to start thinking about. Okay, and then when we look at linkages, this was a study in heart failure, and again, similarly, nothing has been done yet in cirrhosis, but it was a multimodal intervention where they gave education to patients in a teach back style. And then they asked them some knowledge retention questions afterwards. And again, almost a 40% reduction in 30-day rehospitalization. And then lastly, early outpatient follow-up. This was in cirrhosis patients. So they looked again at an administrative cohort of 25,000. 32% had an outpatient visit within 7 days of discharge, which is quite soon. And again, they found that in that cohort, 30-day mortality was reduced by 40%. So many of these things together led us to put together what our intervention is in a way that we believe will be sustainable. And it sort of correlated very nicely with the timing of Connect Care. So the what of our intervention is a cirrhosis care inpatient order set, which has already been pulled together and is just being built. And I've been told by the builders, which everything's been sort of pushed by COVID, but I've been told we're hoping for a January, February launch of the order set. And so the order set will contain, I'll go through a little bit of that in the next few slides, but it'll be hosted on another delivery platform that we're doing, which is our Cirrhosis Care Alberta website. And also as sites move through and get Connect Care, it'll be hosted on that. But we didn't want to just do an order set. So, I mean, I'll go through this in a little more detail. The order set itself has cirrhosis complications embedded within it. It has prompts for follow-up with primary and specialty care. In addition to the order set content, the order set has prompts for education at discharge. And talking to our nurses and practitioners on the units, they wanted something a little bit different than just paper. So we've got paper discharge handouts, which I'll show you, but we've also been designing some videos for this multimedia experience based on what our patient advisory team has said. Big focus on alcohol use disorder management, and I'll show you that this is both for physicians and for nurses that we're targeting this, and then enhanced in-hospital nutrition and activity support. And this is mainly around a nursing intervention, but of course, physicians will need to be on board with all of this. So this is the main parts that our project is focusing on, in addition to working towards enhancing role clarity, this idea of who's doing what. So let me just take you through a basic study overview. And we're using evaluation frameworks like REAIM, looking at our effectiveness outcomes as well as implementation outcomes. We're using several guiding theories with qualitative experts to help to pull some of this data. So the normalization process theory, and then the consolidated framework for implementation research, so CFR. And then using structured implementation strategies. We're implementing at 8 sites across the province. And so we're covering both Calgary at the foothills, as well as Edmonton, 3 hospitals, including the Grey Nuns, the Royal Alec, and the University. And then we're going to go way down south and do Lethbridge, and then up north and do Grand Prairie, and then get Red Deer in the middle. So everybody is, all zones are represented. The entry point is for inpatients. So it's all inpatients with cirrhosis are eligible for the order set and for these additional interventions, which we'll go into more detail on. And as per ethics, no consent is required because it's meant to become a standard part of practice. For the focus groups and the qualitative work we'll be doing, consent will be required. And we are hopeful that all these materials and the website will actually enhance the care of outpatients as well as inpatients. Our key target outcomes. So this is our outcome evaluation. We are looking at effectiveness outcomes like an impact on reduction in length of stay, which is what we were powered on. And so even if we take it down by 10 to 15%, which is our goal, so down from that 14 days to 12 days, as well as a 15 to 20% reduction in 90-day readmission rate. And so from the studies that I've shown you, I hope that you can see that that is something that is potentially achievable. If that they achieve just with one intervention, we're hoping that with several tied together and a whole system change, that we can get to these targets. Just that alone leads to a $16 million return on investment over the period of the grant. We do want patients to be satisfied with our intervention, and so this is looking at greater than 80% satisfaction based on our multi-methods evaluation, and overall seeing an increase in the provision of best practice care across medical and broader health needs. And then order set uptake has been challenging with other order sets, and I think Connect Care will make that easier, but even within Connect Care, that's going to take some work to get people aware of the order set and also want to use it because it makes their life easier. And so let me just tell you a little bit about the different pieces of the intervention. So the order set was developed really very thoughtfully after talking to stakeholders and about what has worked and what hasn't worked in the past. And so unique features, I think, from our end is that we have had provincial consensus. So across the province, we have gotten feedback for what's gone on in there. We've chosen to develop the order set within a medicine order set, which everybody's using right now to admit medicine patients. So we have just taken and copied the medicine order set with permission and then added in the cirrhosis panels. So people are very familiar with the order set already, and then you can just add in panels, which I'll show you below here, that are relevant for that patient. We have an active dissemination plan for residents and for other physicians across the province once the order set does roll out. And again, the Connect Care rollout will assist with this. And then, as I'll show you, the website that we've designed really adds more meat to the order set, in that it provides some guidance for why these things are important and how you do them. So this is just an example of one of the things in the order set around variceal bleeding. And what we've tried to do is add in a little guidance with each of the orders. And so, for example, with non-selective beta blockers, they've allowed us to put in a little bit more information to educate as people are using the order set. The website has come a really long way, and this, I think, is going to be used not only in Alberta, but probably internationally. There's a big gap in this kind of work, and so it's got both a patient side and a provider side. And on the provider side, it'll have easy to follow algorithms that again have been developed with large groups of experts, so provincial consensus on these. Which has enabled us to try and move towards standardizing practice and sort of having a common place that we can all look, or we can direct, for example, rural physicians to look at when they're calling us about these cases. It'll house the order set, so people who are not yet on Connect Care will be able to access the order sets even earlier than when they go on Connect Care, which was another main reason that we wanted to develop the website. And it'll have calculators and other content that'll just make it easier to care for the patients in a, working right within workflow. For patients, we've been working with our patient advisory team. And again, content, I'll show you how much content there is under there for the tabs, but it's been all designed in patient language. We've had editors take it down to the basic languaging, and patients have written some of the content actually. So our group has been really wonderful to work with. This is the kind of information that's going to be on the provider side. So this is the number of tabs, and the number of algorithms will be underneath each of these. And it's turning out to be quite pretty, actually. And we will have also little educational videos and experts and webinars, etc. So we're going to have a fair bit of multimedia content is the vision for each of these. This tab in particular on symptom management will tie in palliative care, which is, again, often not well practiced in our patients, just because of lack of awareness, I think, of the degree of symptom burden, and also lack of guidelines. There's really nothing. So we've had to bring together experts to come up with some solutions, and that has really helped. So having that again on a common site where people can look at it and it can be revised regularly, that'll be very important. Oh, sorry. And then for patients, again, patients having all of these different tabs that they can click on and get more information. And our patients were very clear that they wanted videos. So they said, some people don't really want to read that well, or they don't like that. So we need multimedia. So we've been working with an animator to design little animated videos for, I would say, the majority of this content. And again, many of the scripts written by patients, but definitely all of them screened through patients. With regards to the other pieces, so the discharge teaching, so these are the more pieces that will require direct effort with the nursing units. And this will be our first rollout. So this will be in January. We're going to try and see whether each of the sites can start to standardize and provide cirrhosis-related discharge teaching. So with My Health Alberta, we have created a patient discharge handout, and that is already actually available on their site. And it's got general information, but it's also got additional cirrhosis-specific information if they have those complications, such as hepatic encephalopathy. And, oh, this has a mind of its own, I'm sorry. I was telling Marie about that before. Okay, so in addition to this, we've got a series of discharge education videos, which patients will be able to watch in hospital before they're discharged. And so we're working with the units right now to figure out how best to do that. The second part, once that discharge education video series is running smoothly, then the second part that we'll slowly introduce is the alcohol use disorder management. And this is something that several of our nursing unit teams brought up as being important to them. This was all prior to COVID, but I think with COVID, the number of people who are coming in with addiction-related hospitalizations is growing. And so this I would suggest is becoming even more important. But this is empowering our nurses to start to feel comfortable with screening for alcohol use disorder and giving them basic tools for doing very brief interventions and enhanced conversations. And so again, we're working with addiction specialists to make these video teaching for the nurses. Also for the nurses, then when we move into our third phase of this more interactive intervention, it'll be looking at nutrition and activity. And so we've already worked with nutrition services to design a staying well in hospital handout, and we're working with our physio team to do the same for activity. And similarly, there'll be some videos that patients can watch when they get in, so everybody knows how important these interventions will be then right when they walk in the door. And for physicians, we will have targeted enhanced awareness. So this may come in the form of webinars, most likely now with COVID, just making physicians feel more comfortable with these medications that are so helpful for enhancing abstinence. And talking to physicians about being part of the team to enhance diet orders, etc. So as much as possible, we've rolled things right into the order set to make them within workflow. And these extra things will be done with additional education. We've also started to explore role clarity, and I can't stress the importance of this. I think this will be a really major part of the grant once we're able to have this common place where people come for knowledge. People need to know, okay, what should my role be, and when should I refer, etc. So this is why this is going to be part of the grant. And we've started out with working with cognitive task analysis with our partners Lee Green through Enact. And what they've done to start with is 19 interviews with 9 specialists, 8 family physicians and 2 nurse practitioners. And they've come up with a whole report, which is just going to be published soon. And the main messages from those interviews that they did, so they describe it to me as basically getting a brain dump from people, is main recommendations are that we can't really always plan what's happening in a patient with, in a life of a patient with cirrhosis. So you have to plan for the expected, unexpected, to consider context and journey when you're thinking about designing these interventions, this clarity of provider roles, and then developing pathways and links to trusted resources. And so we're going to try and touch on as much of this as we can as we go through. What we've been up to so far, in addition to all of the content development, is pre-implementation site visits. And so all of this happened pre-COVID, and we did get feedback on benefits, barriers, preferred implementation modalities, and tailoring of the strategies. Because of COVID, we did not plan for this at all, but we will be repeating some of this work and just seeing how the areas have changed as a result of COVID. So that's currently going on right now. We've definitely put a lot of time already into our data collection and evaluation refinement, and outcomes I've put on the left again. But we will be using administrative data for our primary outcomes of hospitalization and length of stay. When we started to do that, the problem came about that there was no clear definition for cirrhosis, and it was quite heterogeneous. So we've spent the first few months actually just validating our own Alberta-wide definition. And that is going to be used as we go forward. We've also been working with Peter Ferris in Calgary to develop our database. We are working with the IHE for economic evaluation planning, and to get data on the patient and family experience beyond just our patient advisory team. We are also, or have already done actually, phone calls from each of the sites, but about 150 patients just post-hospitalization, talking to them about what their experience was prior to rollout of any of this. Immediate next steps for us will be in January. So we're hoping that at that time we'll be able to launch our website with all of the provider and the patient content. And in the beginning, we're going to use it as a testing site. So we're going to have a lot of opportunity for people to give feedback. So looking at it almost like beta testing, and then looking at revising in an iterative way the website content. With the website launch, we'll be doing an awareness campaign with our partners through the physician learning program, and in general across all of the SCNs. Testing the content, like I mentioned, in patients and providers. Fingers crossed, Connect Care orders launch at the university in January, so we're able to start to play with that and see how to improve it as it rolls out to the other sites. Like I mentioned, we'll be starting the discharge education teaching module at the university, again with iterative refinement and subsequent rollout to additional sites. We'll be hoping by January that we have our administrative database, at least the beginning of it, established and testing it. And also we're working with the Connect Care group to try and refine data collection options via Connect Care, and then continuing with our SCN partnerships to develop this role clarity. So having more interviews and particularly around the cirrhosis complications, but also around symptom management. I've learned a heck of a lot so far with this project, and it definitely is a very ambitious project, but these are the key points. I think it's essential to have stakeholder involvement and to really, I think if we want a product that's going to change practice, to really have those voices heard early, because context changes frequently, and who knew about COVID, but you know, this has really changed the way we're going to probably have to roll our intervention out. When engaging with patients, providers, and operations, or anybody, really clearly describing the why and clearly describing the ask, and so making it meaningful for them, ideally, so that they can really help to lead the work. Thinking outside the box regarding delivery of materials and processes, and so we've tried to do that with our multimedia content development. And again, a lot of that is thanks to our patients' ideas. As much as possible, really working with the teams to embed processes within workflow, because everybody is so busy and so tapped out, particularly now. That's been really, really important. And with this size of a project, expect multiple challenges and be prepared not to get down, but to work around them. And when it gets tough, just to bring it back to the patients and to remember who we're doing this all for. So I think those were my key learnings with all of this so far. And I'm sure there will be many more as we go. There are so many people to thank. I can't fit everybody onto the slide, but certainly thanks to Innovates and SPOR for all of the all of the funding support that has made this possible. So I think that's my last slide. And I believe I ended fairly early.
That's okay. We will definitely have some time for discussion. And if people get 10 minutes back in their day, nobody usually complains about that.
This is very true. Okay, I will stop sharing here.
That was incredible. The volume of work that you are undertaking is actually, it's straight up mind-blowing to me that you are just going to overhaul the face of cirrhosis care in Alberta.
Yeah, I think that's the plan.
It's a very brave undertaking. I have a very superficial question to ask to start us off. Who designed your logo?
Oh, it was a friend actually who designed this Cirrhosis Care Alberta.
Yeah,
Yeah, you love it.
it's beautiful. It's beautiful. It's like I look at it as this like, you know, multifaceted liver.
Yeah,
It's perfect. I love it.
thank you. Yeah, no, it was one of my friends. So he's fantastic.
Excellent. So if anybody in the audience has questions, you are welcome to put it in the chat box on Zoom, in the chat box on Whova, or in the Q&A box on Whova. And while you're thinking of those questions, I will ask a couple. So all of your order set rollouts are through Connect Care?
Well, that was the thing, right? Because we know that all of the different sites are going to go on to Connect Care at different times. So
Yeah.
we didn't want to have Calgary, I think, is next year sometime, and some of the southern sites are even later. So that would mean that the area under the curve for our order set would be super small for those. So that's why we thought we need to develop a website. And then the website got a little out of control with, okay, patients want stuff on there and we want videos and providers want stuff. So it sort of blossomed, I guess, into something bigger to support the rollout of the order set.
So do you think you'll be able to compare the sites that got their order set implemented through Connect Care versus online versus are there sites that won't be implementing it until the project is over?
There will, so, and that's really cool about Connect Care is that it's going to be more of an active strategy ideally, or I suppose maybe not active, it's actually passive, isn't it? Unless we're going into the sites and saying, hey, use this order set, which is it's a problem with some of the order sets. I was chatting with one of my colleagues who designed an admission order set, and she said, you know, nobody's actually using it because people don't know about it. So I think it'll be interesting to compare sites that didn't get us going in and saying, this is really important, this is around, you got to use this, and it's just sort of disseminated via Connect Care and it's there, versus the sites where we really do go in, do our little talks and everything. Yeah, I think that'll be really interesting.
Yeah, a really interesting kind of byproduct of the design. I like it. Christine is asking, was this your first application to Prius, or had you applied for or received funding prior to developing this large project?
Funding, Christine, related to this particular project? No, I hadn't received a Prius before, so this was our first application. I had received smaller funds just for quality improvement, but like we're talking 30, 50,000, those sort of things, just small projects.
That kind of formed the basis, like the foundation for this large scale overhaul in Alberta.
Yeah, but I think the gaps were just so apparent and so not covered well to date that's why it was fairly appealing.
Well, and especially with that large return on investment, it's kind of a no-brainer.
Yeah,
right?
it's
Like,
low-hanging fruit.
And based on the evidence that you showed versus like even with a very realistic goal of the 20% reduction, like it just makes so much sense.
Exactly, that's what we thought too. Yeah.
It sounds like you have a super engaged patient partner group. How did you find them?
We asked our provider, I guess through the Cirrhosis Care Clinic, we had a lot of patients that we had access to, but we wanted a diversity of patients. So we asked our partners across the different sites whether or not they would put up the little poster and recommend patients to be on the advisory team. And then we had people reach out. And unfortunately with this group, they're sick. So things like deaths and transplants, et cetera, happen. So then we do have to get more patients as we go. But we did want to get that diversity across the province, diversity in ethnicity, diversity in ages. So just a larger group was nice for us. So the 15 to 20 is what we started with.
And was there any, did you seek out anybody with specific skill sets, or did you equip them with any sort of training?
Our patient lead is amazing because he's got a communications background. And so he's written a lot of our resource materials because he's so good at that. That's what he does. Yeah. So he's a co-lead on the project, Derek. And then there was a younger gentleman also who was very good at social media kind of things. So we didn't recruit particularly for talent, but it just comes, I guess, with the group.
Yeah, so you kind of find the areas that they're interested in once they're on the team, and then, hopefully everyone is so lucky to to end up with such skilled patient partners.
It's amazing, and I just can't speak highly enough about how important it is to ask. I didn't used to do that when I initially started practice, but then very shortly after, I always involve patients in my research, and it has just made the world of difference.
Yeah, preach into the choir at the Virtual Institute here.
have to do that.
Yeah, absolutely. And this is not so much about your project specifically, but maybe it's just a technical question. What is the actual mechanism of action in Connect Care for, say, an emergency department physician to follow up with primary care?
I think that's a loaded question.
Yeah. Okay.
Yeah.
Ignore it then.
Right now, everybody's coming on at different times, and I'm not sure that primary care necessarily is coming on very quickly. So I don't know all the details behind that, but
yeah.
There is definitely room to improve, I think, in the way that we communicate. Connect Care will help. It'll be a start for sure. And hopefully we'll continue to build on that.
Yeah. Well, I'm happy to have someone as ambitious as you tackling these kinds of workflow issues in Connect Care.
Yeah, no, it's really helpful to actually be in practice and just see what the gaps are and be like, gosh, we can't do it like this anymore. Yeah. So for example, me telling my patients, you have to, my transplant patients, pre-transplant patients, you have to stay strong. Otherwise you might get taken off the transplant list, but then we don't give them enough tools to really be able to stay strong. So this will help with that too. And even in hospital, the amount of muscle that they lose in 10 days is 20% of their muscle they can lose. So it's ridiculous. So you gotta give them tools to be able to actually empower them to do what we are asking them to do, right?
Yeah, absolutely. I think one of the slides that really impacted me was the way it is now with everything you're asking of your patient, and it was like 12 different things all coming off, and no order. And I can only imagine how confusing that is for both the healthcare provider to be like, oh, well, have you done this and this and this, and try to keep track of that, as well as a patient trying to schedule and make sure they get the right referrals. And
especially if confusion or other things that as part of their illness, it's really challenging. And for the caregivers too, it's really challenging. So honestly, there are so many more things that I wish I could focus on, but I just can't do it all over the next.
I think this massive project as step one is pretty good. Christine is asking if you have started with making the videos and what type of approach will you be using for the videos? Is it patient voices, animation, etc.?
Yeah, that's a great question, Christine. So we have started. The narration for the patient videos. So I guess the patients are not necessarily the main people in the video. So it's still going to be a physician or a nurse or a healthcare practitioner sort of talking about one of the topics like fatigue management, etc., ascites, sort of letting them know about that. But so that will be in the practitioner voice. There will be some videos. We've done one where patients are actually in it in real, so not an animation, where it's how they cope with eating a low salt diet. And so their strategies, their 101 around that. So it'll probably be a little bit of a mix, but the majority of our videos will be animated. And that's been really, really well received so far by the patients. I think that's going to be one of the big wins.
I think so. I know how intimidating it can be to pull up like 8 different web pages with like a bunch of text and try to read them all and figure out what is it actually trying to tell me.
And plus practitioners are busy too, so it's nice. It's nice to be able to know that there's a source that you can refer your patients to that has the information on there and that they can listen to it or they can read it. They can do whatever suits them, their style best, I guess. So that we can then say, okay, why don't you go, and my vision would be anyways, look at this, and this on the website, and then next visit we can chat about it if you have any questions. But it's challenging to take the time, even on the hospital units. The nurses said, we don't have time to sit with a patient and go through everything when they're being discharged. So then we came up with the idea of videos together. So it's like, okay, would you play the video for them?
The pre-hospital discharge videos, that I love it.
And other groups do it, like Stroke does it. It's not new, but it's new for this group.
Yeah. And I think it could make a huge difference.
Yeah.
All right. So I'm going to give an awkward silence while we let everybody get their last minute questions in. All right, seeing none. I would like to thank everyone. I would like to thank our speaker, Dr. Puneeta Tandon, and all of you who attended today. Please continue to post your questions and comments for this session in Whova. The recording of this session will be available to watch in the app within about 24 hours. We would love your feedback on this session, so please click the rate session button on the session page in Whova to open the feedback form. We invite feedback from those of you attending live today, as well as from those of you watching the recording of this session, and same goes for if you're watching other people's recorded sessions. Reminder that our Twitter contest for favorite poster and video abstract is still open. Be sure to vote for your favorite, and the winner will be announced after our closing plenary session on November 20th. And with that, I gift everyone back 10 minutes of their day.
Thank you, everyone. Thank you, Murray.
Thank you so much, Dr. Tandon.